Dr. Garvit?
Hi, I am Dr. Garvit, and I work at Nanavati Max Institute of Cancer Care, and I've been meeting them very often, ma'am.
So whenever I meet them, they're crying buckets still.
Oh, how come I don't get to know this
I
directly?
thought you must know. You must feel good about it. Dr. Tabassum?
Yeah, hi. I'm radiation oncologist and practice breast oncology at Tata Memorial Hospital, Mumbai.
Nice to have you, Dr. Tabassum. Dr. Jyoti Vadha, my friend from God knows how many years, I've forgotten how many years we've known each other.
Since 1987.
35 years.
Yes.
Yeah.
So I'm Jyoti. Yeah, I'm roll number 31 from Lady Harding Medical College, and Geeta is roll number 32. So I went on to become a medical oncologist. I did my MD/DM from AIMS Delhi, and currently I work at Medanta Cancer Institute as Director of Medical Oncology. And it's obviously a pleasure to be back to meet and be with you all, especially when invited by Geeta. So thank you, Geeta, for giving me this opportunity.
Thank you for coming.
Thank
And you
you.
know, na, she was the most padaku bacha, और हम तो, you know.
Not at all.
Yeah. Dr. Aparna. Dr. Aparna is the genetics person. I thought, she's also going to add value to this discussion. So, Dr. Aparna, please go ahead and introduce yourself.
All right. Hi, good evening, everyone. So my name is Aparna. I am a trained medical geneticist and genetic counselor. I've been in the realms of genetic counseling and genetics for around 15 years. My area of interest has always been female cancers, breast and gynecological cancers. So happy to be here, and thank you, Dr. Geeta, for having me here today.
Thank you for joining in, Aparna. And Dr. Puneet Kochar.
Good evening.
So, Puneet means, you become a fertility specialist.
Sorry, Dr. Geeta, I got a little late in joining.
No problem. Go ahead and introduce yourself.
I'm Dr. Puneet Kochar. I am a fertility specialist at Elixir Fertility Center. So this is in North Delhi near Model Town. And I'm originally from Maulana Azad, but I did my fertility IVF training in Bournehall, UK. So I was in Bourne for 3 years, and I've been back since 2014 now.
Nice to have you on board.
Thank you so much, ma'am.
So I think we are good to go. We're at 7:05. A very warm welcome to all the lovely panelists and experts, and of course our own team. Dr. Rajat Saha, he's a medical oncologist with us. Dr. Vinita Goyal is a radiation oncologist at Fortis Shalimar Bagh. And we also have Dr. Vikas Goswami, who is a medical oncologist with Max Hospital again. So we have chosen this topic because I think primarily it is going to be an interchange of ideas. I think it's high time we talk about fertility preservation just as much as we talk about the treatment of cancer, especially in young women who may not be desirous of anything at the time that they're diagnosed with cancer. But I think this counseling is very important, and we do need to take it seriously, and everybody has to create that cosmos around themselves, because you do need a fertility specialist in the picture. So you have to seek them out, you have to push one of your gynecologists to become one, because it is very, very important that it reaches every nook and corner, because I think everybody has a right to reproduction and to have their own children, and we have no right to deny it just because we think the treatment of cancer is more important. So let's get going. Is the support team ready? We had a pre-poll before this program came on, and I would request them to just put up the questions just to understand how fertility sits with clinicians and what are we doing about it. So can we have the poll, please?
Just give us a second. We are sharing in a while.
Hello.
Yes, ma'am.
Can we have the pre-polling result?
Yes, just give us a minute, ma'am. There is a technical issue.
Shall we start then? We can do it. Yeah, we can start and we can stop again and after the initial bit and then see how it goes from there. So I'm going to share screen now. Okay. Can you see it?
You can make it full screen, please.
Just a second. Just a second. I'm having some trouble here. Just a second. Okay. Okay, can you see it now?
Yeah.
Okay, so let's get going. I think I've already introduced most of you. You've all introduced yourself. So Dr. Ullas Batra is missing in action, but I'm sure he'll join us shortly. He's possibly tied up with something. And Dr. Amit Agarwal was to be the crown expert, but he's down with a viral fever. He will not be able to join. Dr. Rajat Saha will sum it up in the end. So we just want you to want to start this whole thing on a positive note, and we want to tell you that this is actually a happiness project. If you were to pay attention to fertility preservation, it could land up being the biggest happiness project for each patient who undergoes cancer treatment and lives long enough to tell the story. So I will request Dr. Vinita to take us through some happiness slices. Over to you, Vinita.
This is a picture of a young doctor. She's a gynecologist herself. She was married. And after a year of her marriage, before she could conceive, she was diagnosed with breast cancer, triple negative, and quite advanced, locally advanced breast cancer. So at the time of diagnosis, there was obviously a panic in the family. She herself is a gynecologist. Husband is also a doctor. And so are in-laws and there were several other doctors in the family. So there were multiple cross consultations happening, and it was very difficult for the family to accept that at such young tender age she had breast cancer. So in spite of being a gynecologist, in spite of being there being a discussion for oocyte and embryo preservation, it was not done. However, she was treated with neoadjuvant chemotherapy, and then she had surgery and radiation therapy. And she, I was very happy when she had sent me this message. 2 years down the line, she had sent me this WhatsApp. It's a girl. So the message is that we have to pay attention to these factors, which can bring a lot of, completion or happiness, not only to the patient, but to the entire family. And as they say, that do not die before you are dead. In the same spirit, I would like to share about another young patient that we had treated some time back. Next slide, Geeta. So this patient of ours was 30 years when she was diagnosed with right breast cancer. It was T2N1, triple negative. She was married. She already had a 3-year-old boy. And because there was a 3-year-old child, I think again we missed having a discussion about fertility preservation.
And the other reason being that probably 10 years back, these discussions would not happen so often also. She was treated with surgery, chemotherapy, and radiation therapy. She was very desirous of having a second child, and she had a normal child, second baby, 4 years after completion of treatment. Next slide, Geeta. So she was, after having this child, after her previous diagnosis, she was disease-free for 10 years. She had a local recurrence. She underwent mastectomy. She was happy to have mastectomy next time because she said, I have done my job of at least feeding my babies. And now she's on hormonal therapy. And you can see the happiness in the eyes of the whole family. Next slide. Geeta, will you talk about this?
Okay, so this is the year 2011. A 26-year-old doctor engaged to be married to a surgeon in training, diagnosed with hormone-sensitive CA left breast. She underwent wide excision plus sentinel node biopsy, and she had chemotherapy, radiation, and hormonal. Soon after her surgery, that is when she decided that she was going to have an embryo preservation done. Now, I am not sure how it was, because I don't know what the implications are, because they were not married at that time, because the marriage happened, I think, subsequently. She tested negative for BRCA1 and BRCA2. So she had the embryo preserved, but it never came into use because she conceived naturally after completing 5 years of hormonal treatment. And our son is 5 years old, and she just, pounced upon me one day. She just walked into my outpatients with her son. And I can assure you, so much as it is a joy for the patients, it is a huge joy for us as well. So that is there are more examples. I'm sure we all want to create these happiness projects for ourselves and for our patients, and we must strive for it, and that is what this discussion is going to be all about. So are we now ready with the pre-poll? Pooja, are we ready with the pre-poll?
Yes, ma'am.
Are you ready? Should I stop sharing?
Yes, ma'am.
Okay. Okay. So this was the pre-poll. So we asked this question, and how many? These are the number of people who participated in this poll, and that is 83 plus 7, about 90. So do you discuss parenthood and fertility preservation options with your young breast cancer patients? So we get a whopping always, that is 76 of our colleagues do always discuss parenthood and fertility preservation. 17 say, well, sometimes, and there are 7 who think it is not important. So next question, please. So then we asked, what are the barriers to initiating a discussion on fertility preservation in them? So we do say that it is possible that there is a poor understanding of what the process entails. So if this question had been asked of me about 5 years back, I would have possibly marked number 1, because there was a poor understanding as far as clinician goes. So there are about 12 of them who say, well, there is a poor understanding. The second is also very, very true, that there is a reluctance on the part of the patient, especially in locally advanced disease, where they think that is not important. They think the oncology bit is important. So about 80 of them say that is possibly the reason. Then fear of delay of treatment, both on the part of the clinician and patient. Again, 13 of them said yes, that is possibly the reason. And lack of fertility specialists in the hospital or vicinity. So this is good news, that is not such a big factor. So there are a lot of fertility specialists coming into play. Next question. So we asked them to rate each on a score of 1 to 3, as 1 not at all confident, 2 somewhat confident, 3 very confident. So we said, how confident are you of the various fertility preservation concepts? So a lot of them saying ovarian tissue preservation. Well, it'll be interesting to hear from our fertility specialist, because whether it is a recommended thing or is it purely on a trial situation that you should be doing ovarian preservation, by and large, it is oocyte and embryo preservation, if I'm not mistaken. So this is something that will get corrected during the course of our discussion, I'm sure. Next question. How important is it for you to know when to refer, how to initiate the discussion, what to offer, and when to find the window to allow pregnancy in your patient? So that is something very, very heartening to know that about 98% of the participants thought that it was very important. And there is hardly anybody who thought, least important. There was there is just 1% which said treating the disease was important, which of course we all understand. Treating the disease is of course important. I think those were all the questions. Yeah. So that is the pre-poll. I think now it is time for us to go back to the discussion, and I will now invite Dr. Rajat Saha to take us through the first case. So this is how this fertility saga actually plays out in real life, and we're going to take you through different case scenarios which you would have definitely come across. And this is Dr. Rajat Saha taking you through this first case scenario.
Thanks, Dr. Geeta. And definitely, we all want to create happiness projects in each of our patients, and that is the endeavor. From what I could gather from the online poll is two things which I could gather. One is 76% doctors want to discuss or will discuss fertility related issues with their patients before starting the treatment. And second is 98% want some referral or something in. So on the whole, we have got a very receptive audience who would like to definitely understand, me included. I would like to admit that we kind of grossly underplay this aspect of the treatment, which actually should be very much in the forefront. So to bring out the various salient points in this very vital issue, we have got various case scenarios. I'll be discussing the first case scenario. We have a 31-year-old lady. She was married, was separated, and was keen to remarry. She already had a child, 8 years old, from a previous marriage. And unfortunately, she developed carcinoma of the left breast with initial staging of T3, N3 by the virtue of a small supraclavicular lymph node, and hormonal profile read as ER/PR positive and Her-2 negative with a Ki67 of 60%. It's kind of a luminal B, kind of a aggressive hormone positive breast cancer is what I can get. The hereditary breast ovarian panel was negative. It was done at initial presentation and it was negative. So she has been planned for, she was planned for neoadjuvant chemotherapy based on the initial staging. And as always, the family is generally always in a state of absolute panic. So next, I would like to kind of, Dr. Geeta, if you can move on to the next one. We would like to kind of ask our practicing oncologist at this point of time. We can start with Dr. Garvit from Max Nanavati. So you have received this patient in your clinic with a locally advanced CA breast. Do you discuss fertility issues seriously with the patient and rope in the fertility expert at this point of time? And what do you think are the roadblocks which prevent you from successfully navigating the fertility issues? I would like to have Dr. Garvit for his opinion, and then I can ask Dr. Namrata.
Right. Thank you, Dr. Rajat, for the question. For a young patient, I would always start with I know it becomes a little difficult in the first appointment, because what happens is when you're talking about, especially about a locally advanced disease, it's first comes the breaking bad news part, and then you're talking about the stage of the disease. You're already talking about what next to do. You're discussing the chemotherapy. You're discussing the side effects of chemotherapy. Since it's a young breast cancer patient, you would also discuss the genetics and ask them to get a genetic test done. And then comes the fertility. Now, I always make it a point to, whenever it's a young breast cancer patient, to include these two extra points while discussing treatment, is genetics and fertility, because otherwise it becomes an issue later on. And I've, earlier, when it was not so clear on what needs to be done and when it needs to be done, there were patients that we were missing, and when they came back, questioning on why we were not told was a difficult and a sticky situation. So there are roadblocks, and I would, if you want, I have a short presentation about 3-4 slides. Should I make it now, or do you want?
If you can summarize, Miss,
Yes,
what
definitely.
do you think are the roadblocks?
So when you talk about clinician related roadblocks, a lot of times what we are thinking is which one to choose from. Obviously, you've just seen in the pre-poll, you saw that people have chosen ovarian tissue preservation as one of the procedure of choice. While, like Dr. Geeta rightly pointed out, even the ASCO guidelines called ovarian tissue preservation as a procedure of choice, as a procedure which is being carried out only in the experimental this thing. Yes, some countries are using it regularly in the clinic, but US, as per the ASCO guidelines, is not using it as a approved clinical method of ovarian tissue of fertility preservation. Now, younger patients, they present with aggressive subtypes, like the patient that you said in a locally advanced breast cancer. The whole discussion changes to how the disease is going to pan out, what is the survival that we are expecting, and that makes it a little difficult to bring in fertility in the first appointment. But yes, we do make it a point to get into the later on, get the discussion in the later stages. Like I said, too much to discuss in one go, where you're breaking bad news, stage of the disease, outcome, conservation, reconstruction, everything, and then you're talking about this. Now, when you talk about patient related, it also depends on who's making the decision for the patient. A lot of times in the Indian scenario, we see that the decision maker, while taking the treatment, it's not the patient who's deciding. But it is an important thing that we mention it when we are talking to the patient, so that at least the patient hears it and knows that there is going to be some effect on the fertility because of the cancer directed therapy that we are going to offer. And at least that discussion starts in the family. They may come back a day later and say, like, you mentioned about fertility, and I think we should go for it. And that itself is enough. Sometimes that small spark needs to be put there. Obviously, from the patient point also, fear of the disease is always there, and a lot of times patients will come and they'll deal with this first kind of attitude. I don't want any other thoughts put into my head right now, just deal with the cancer first.
That kind of is the most common scenario which we face in our our Indian situation. Basically, the patient comes forward and tells, you can put it on back burner. Let us start with the chemo or the surgery or whatever first. Dr. Namrata, can we get a perspective from Ranchi, means where you're practicing? Do you think there are roadblocks for discussion on fertility issues? Dr. Namrata, can we have one?
Absolutely, sir. Like Dr. Garvit just mentioned, sir, when you're meeting the patient for the first time, first or second OPDs, when you're breaking out the bad news, of course, there's too much for the patient and the family to, understand as to what is happening to start off with the treatment. Fertility issues are discussed, but they are towards the end of the discussion. Now, like Dr. Garvit mentioned again, I usually put in just the, just an introduction that this is possible. So when the next meeting comes, there are times when the family members are interested rather than the patient, that, patient is probably not in that phase where she wants to discuss any of this. For her, it's just the disease at that point in time, but it's important for us to put forward. Now, specifically when you ask about this patient, sir, in tier 2 cities like Ranchi, I would prefer to discuss about fertility preservation when I have the biopsy report. So my ERPR status takes time, say around a week, 10 days to come in our place. So, I have that at least 10 or 12 days of time to discuss this with the patient. And in fact, if I have to send her for any of these ovulation stimulation for this patient, especially, either I'll have to go in for an oocyte preservation. So if I have to at least consider an oocyte preservation, I'll at least take approximately 2 weeks. And by then my ERPR reports are also available. But in this particular patient, when all my reports are available, it's a T3N3 patient. I'm not sure how much the patient is willing to wait. I'm not sure how much I am going to take the chance of waiting for another 2 to 3 weeks. Sir.
Correct. So overall, what I gather is, at least after discussing this important issue for the next 1 hour, at least the clinician related inertia should go. We should at least drop in the option of fertility preservation, the various techniques of fertility, and then let it means fall on the patient to decide. So let us carry forward the discussion. Let us hear it from our fertility experts. We have Dr. Tanya Bakshi from Max family, and we can hear from her what are the chances of this kind of a patient having a successful pregnancy if she were choosing a fertility preservation option. So this particular may be a locally advanced EF breast. Let's see what Dr. Tanya has to say about it.
Thank you very much. So I would definitely want to give this patient a chance, and it's very heartwarming right from the poll to know that all our colleagues, be it the medical oncologist or the surgical oncologist, are putting this forward. And I think I would like to allay the anxiety as well, be it tier 1, tier 2, tier 3 cities, that yes, these patients are very much capable of having their own pregnancies. We've seen the stories of where actually there were natural conceptions. So which method is going to allow them to have a pregnancy, I think the fertility expert can discuss with the patient and take it forward. And we are here to take this discussion in depth. So I would understand if the medical or the surgical oncologist have a lot of discussion to do related to cancer. That's why we are important to take this discussion further. In this patient, what I would like to say is that generally when we compare the breast cancer patients to the patients who've never had a breast cancer, their fertility is a little bit lower. There's a lot of mixed data here, but we must look at the ovarian reserve of the patient. The positive in this patient is she's already had a child. She's a young patient. Now we would have to assess her ovarian function, be it in terms of with hormonal testing like an AMH, and I'm sure all of you are aware now, and I'm quite happy to know that often, even before the patient is sent to us, AMH testing has already been done and advised. And as Dr. Namrata said, sometimes there is a 10-day or there is a period. Please send us the patient initially. Don't wait for the reports. So if you've had this consultation, and even if the patient is awaiting further testing, if she can meet us before, then we get a lot of time to counsel the patient and take the treatment forward, because time is of essence. Whether we take 2 weeks or we take 3 weeks, the sooner you send it to us, the sooner we can get going. So for this patient, as you said, she's 31. What are her chances of pregnancy? I mean, it would depend upon her ovarian reserve. So be it in terms of an ultrasound where we assess the antral follicle count, we look at her AMH, and we look at her individual parameters as well. So I said someone who's conceived before generally is a good candidate to conceive again. She's young, but I don't know what her AMH is, and I don't know what her antral follicle count is. However, when we do counsel these patients, the critical decision is, because we have this window for fertility preservation before she's going to go ahead for chemotherapy, we must have a discussion that yes, there is an option which is very safe. And I know Dr. Namrata did talk about oocyte freezing. I'm a bit surprised that people would think in the poll that's ovarian tissue cryopreservation. It is not. So when we look at the standard of therapy, the standard of therapy for this patient would be oocyte cryopreservation. Now, looking at the time frame, we usually take anything between 2 to 3 weeks. And if you want me to go more in detail about the protocols, I'd be quite happy to share. But for this patient who's hormone receptor positive, in my practice, what I usually use is the letrozole, the aromatase inhibitor. So what we want to do is keep the estrogen levels low. What we don't want is to push her into a risk of ovarian hyperstimulation. And we want to make sure that we are finished in a certain duration of time where we get a good number of oocytes to freeze, and she's safe enough to be handed over back to the oncology team so that her chemotherapy can be started. So there are protocols where they can be using tamoxifen, the SERMs, or you can use the letrozole. The good part is we're good to start at any time. So they are gone are the days that you wait for a woman to get her period. So even if she is mid-cycle, she is in the end of her cycle, which is called the luteal phase, we can start the stimulation then and there. There's also something called a double stimulation, whereby in a certain time frame of a menstrual cycle of about 4 weeks, we can do 2 cycles of stimulation to collect more oocytes. So this is where the MDT is very important. So I would discuss with Dr. Namrata, I would discuss with Dr. Garvit, and together we would take the decision, because she is someone who's needing neoadjuvant, to how much time do we have? Is it good enough for just 1 cycle of stimulation and oocyte freezing? Or do we have time enough for doing something called double stimulation, which is 2 stimulation essentially to garner more oocytes for freezing?
So what time in days? What is one ovarian stimulation?
So anything between 2 to 3 weeks. So let's say we see the patient today, and we typically depends upon the response of the patient. A stimulation cycle could range anything from between 8 days to 14 days to get the oocytes to a level of maturity, and then would be the egg retrieval. And generally speaking, couple of days post-surgery, because we take the oocyte retrieval, as I said, the aim is to not hyperstimulate the patient, to make sure that we don't put her at a risk of hyperstimulation post-egg pickup. So in total, maximum 3 weeks. So if someone were ready in 10 days, her egg pickup would be on the 12th day, and post-egg pickup, give her about 2-3 days, and then you're good to go. If I'm doing a letrozole-based protocols, what we want to do is continue the letrozole for a time, even post-pickup, so that we keep the estrogen levels low. In certain cases, the antagonist that we're using, we will continue the antagonist post-pickup as well. So what happens, the suppression of the ovaries continues, and the estrogen levels drop quite quickly. So the whole aim is not to have very high circulating levels of estradiol. You want to keep it low. And we check the estrogen levels even post pickup if they're high. So let's say they're still not suppressed, then either, as I said, continue the antagonist, or you continue the letrozole, or you can have both of them going together. And then once the estrogen levels are low, the ovary is suppressed, she's actually fine to go ahead for her chemotherapy. It's a very safe procedure. It's a daycare procedure. And if you've not pushed the patient too much, there is very low risk of hyperstimulation, because we're stimulating in an antagonist cycle, keeping the estrogen levels low, pushing the trigger, which is the injection for the final oocyte maturity, using the agonist. So we're not using HCG. And we know the HCG tends to have a prolonged effect. So what we're aiming to do is get this patient quickly ready to come back to you guys so that you can start the anti-cancer treatment.
So that is a very good encouraging comment from you, and I'm pretty much liking that letrozole plus GnRH analog combination. I think so. This will give a good consolation to the medical oncologist also, that ultimately you're reducing the estrogen levels, and we can at least say that yes, the patient may not run the risk of increasing the breast cancer.
Absolutely. So there are protocols where they've used tamoxifen as well. There are some who've done it in a natural cycle as well. But I think the ultimate aim is to balance the two. And what you need to do is get the right amount of stimulation to get a good number of eggs. So remember, this is not just a tick box that we're doing, that yes, I preserved 3 eggs and it's giving you a good chance of pregnancy. So what I would like my colleagues to also understand is that it's age-related phenomena. We know that cancer, because of it itself being a catabolic state, and because of the other, maybe we've still not understood the processes yet, that there sometimes oocyte yield is less. Yes. Some studies have said that actually hormone receptive positive patients do poorly in terms of oocyte stimulation as well. So this counseling is very important, because as I previously said, it doesn't stop by just freezing the eggs. We have to go a long way to finish the therapy. She comes back to us. Then we would have to perform an ICSI with her, either her partner, her husband's sperm, or a donor sperm, if she's still not married, to create the embryos and then put it back into her uterus. So I think the entire journey has to be discussed with the patient, with the oncologist. What are we doing? And just the oocyte freezing is the first step. But what we have to reassure as well, that once she completes it and undergoes a pregnancy, it really is very reassuring. It does not impact even the disease-free survival. In fact, some have studied and they've showed that pregnancy is beneficial, and it should be reassuring and encouraging to the patient that this process, which will eventually let her to get to be a mom, actually has a positive impact rather than the reverse, where people have a mind block that it's negative.
Correct, correct. So that is excellent. So yes, our initial inertia is broken. We have got a good consultation from our fertility specialist, and in this scenario, per se, the patient and family declined to consult a fertility specialist. She was treated with the standard NSAT followed by breast conservation surgery. There was a residual focus of disease, and she underwent radiation and subsequent hormonal therapy. Because she was young, a combined therapy with Zoladex and tamoxifen. So 1 year later, she was on follow-up. She was disease-free. She wants to remarry, and she's also keen on having another child. So she, mind you, she is still on Zoladex and tamoxifen. And now I would like to bring on board Dr. Jyoti. We all know that this is a high-risk disease. So when can you give her a window period? When can she potentially conceive? Dr. Jyoti.
Right. So as you rightly said, she is high-risk patient. Why? Because she is younger than 35 years of age. She's 31, I think. And she qualified as an indication for getting neoadjuvant chemotherapy. So both these factors make her a high-risk patient. High risk means that there is significantly high chance of her getting the breast cancer recurrence. So in a case like this, pregnancy is usually not recommended in the first 2 years. This is because the chances of recurrence are the highest in the initial 2 years. Even though if you look at the other side of the coin, this recommendation is not made because pregnancy will affect the breast cancer outcome. It's just to ensure, as I've written here, that women should not become pregnant while they are, in the early recurrence, because it will make the matters worse, both for the patient and the fetus, developing fetus. So to play it safe for both the parties, it's best to wait for 2 years in a case like this. And obviously, this 2 years, this would apply to this given patient that we are discussing today. However, if it wasn't high risk, if it was low risk, then there is a suggestion that one then need not stick to this 2-year cutoff. One could modify the recommendation of this interval to conceiving based on the disease characteristics, the patient characteristics as are listed here. So if somebody was low risk, one need not wait for 2 years also, but one has to be very judicious in classifying a patient as low risk or high risk. So this patient, I would want her to wait for 2 years.
At least, yeah. So we all have our choice of chemotherapy. So do specific chemotherapy regimens affect the quality of the oocytes? What your take on it?
Yes, so as listed here, so we classify the various chemotherapy agents that we use for treatment of breast cancer into high risk, intermediate risk, low risk, very low risk, and also there are now newer drugs about which we do not know as yet as to how they affect the fertility of a given case. So as is mentioned here on this slide, the drugs such as alkylating agents, namely cyclophosphamide, which is often an essential component of the breast cancer chemotherapy regime, is very gonadotoxic and therefore comes in the high risk of infertility. The criteria is not just dependent on the drug used. Mind you, it's also dependent on the age of the patient. So as is listed here, a particular regime may, depending on the age, be high risk or intermediate risk or low risk, taking into consideration the patient's age as well. So we very commonly use the AC followed by T, 4AC followed by 12T. So depending on the age of the patient, it could either be intermediate risk or sometimes the 4AC itself, when used in very young women, may belong to a low risk category. So high risk like cyclophosphamide, intermediate risk such as anthracyclines, and low risk such as taxanes or the vincristine, vinblastin kind of drugs.
Correct.
So that's the classification.
Fair enough. And we all generally nowadays follow an ovarian functions suppression protocol based on the soft and text data. And what do you think should be the duration of the gonadotropin analogs in your patient or a patient like this?
So in a high-risk case like this, point is very clear based on various studies, including soft and text trial, including their 8-year updated analysis, the initial ASTRA study, and more recently the EBCTCG meta-analysis, that ovarian function suppression is beneficial. Number 2, the duration. Some duration, namely say 2 years, is better than no ovarian function suppression. But preferably, it should be 5 years of ovarian function suppression with the Zoladex or triptorelin. In soft and text, triptorelin was used. It's preferable to be used as monthly rather than 3-monthly regime to ensure uniform ovarian function suppression. So given a choice for this patient, I would recommend 5 years of ovarian function suppression.
Correct, correct, correct. So what is the good time to safely stop hormonal therapy, to give her a window period, and give her time to plan her pregnancy? So you have said that you will definitely like to continue GnRH analogs for 2 years compulsory.
Yes.
And after that, when do you want to give her the window period to conceive?
So then, this patient went on to get tamoxifen and Zoladex. So in this given case, she should receive it at least for 2 years. And then she should be off tamoxifen for at least 3 months to wash it out of the system and then only conceive. Because if she conceives within 3 months of receiving tamoxifen, then that could affect the fetus. That could have some teratogenic effects on the fetus, developing fetus. Similarly, in another case, as I have listed here, if the patient had received trastuzumab, it's very important to ensure a 7-month free period of trastuzumab before attempting pregnancy. So it's very important to know the drugs and their washout periods to help the patient plan pregnancy.
So these are excellent points which have been brought about by Dr. Tanya and Dr. Jyoti in this first case scenario. We still have a lot of other case scenarios to discuss, and I would like to hand it over to Dr. Vinita for taking us through case scenario 2. Thank you, Dr. Jyoti and Dr. Tanya.
So I think our case 2 is also very similar to case 1 in terms of patient profile, but it is a slightly early and more favorable breast cancer. So the patient is a 35 years old lady who had left breast cancer mucinous subtype and underwent breast conserving surgery after initial workup. And histopathologically, it was a 2.5 into 2 centimeter tumor, mucinous carcinoma grade 1, DCIAS was present, and LVI and margins were free, and so were the nodes. And she had a stronger ERPR positivity of about 8/8. Her-2 was negative, and Ki-67 was only 10%. She was planned for hormonal therapy and radiation therapy. She refused for oncotype DX, as well as she was not considered for chemotherapy because it is a mucinous carcinoma grade 1. Next slide. So this patient has a more favorable disease and prognosis. She's already married. She had 1 child at the age of 35, but she also wanted to have another child. And her question was that when can she safely stop hormonal therapy and plan a second pregnancy? I would like to first ask Dr. Ullas Batra regarding the safety of planning the second pregnancy in a strongly ERPR positive breast cancer.
Is Ullas there?
I think Ullas is there.
Can anyone promote Ullas from delegate to panelist? That is, so the organizers have to do that. He's there.
Yes, he's there. Please promote him as a panelist.
I think meanwhile we can ask Dr. Jyoti.
Yes.
Dr. Jyoti, what are your views on this?
I will remember this, Dr. Geeta and Dr. Rajat and Dr. Vinita. Wait, before I give you my answer, I'll remember this, okay? I had to wait for 20 minutes to be promoted as a panelist. So just wait.
Okay. Cool it.
Well, Dr. Ullas, your turn to answer. I was busy on a phone call also.
You're just in time, Ullas. Nahi to fir hum bhi dekh.
Next one. So what Dr. Vinita has asked me is the easier one for the medical oncologist. And especially knowing Geeta and Vinita, is there ever an easy question for us? So I don't know there's an easy question. So what we do know, as what Dr. Jyoti very rightly said, was pregnancy after the diagnosis of breast cancer is safe, is feasible. And Dr. Tanya very rightly said was, there are some studies which have said that there is absolutely no increased risk and maybe a detriment. I mean, it's a better overall survival. Although I would like to say that there could be a selection bias in that. A washout of 3 months for tamoxifen has to be given. That is the most important thing. I mean, we should always remember. Pregnancy should be avoided in the first years of diagnosis. As Dr. Jyoti had said, this patient is a low risk. She is 35. What we don't know right now is 3 years versus 5 years. So I think I was just reading the chat question, what Dr. Tanya said, and I think a realistic counseling has to be done with the patient. It's very important for us to ask them and sit across the table and say, vis-a-vis disease progression versus a disease recurrence versus pregnancy. What does she want more? You don't want to get a child and then you don't want to get a recurrence. So that's a discussion that we need to have. A positive trial is a trial in which we are getting a thing which is going to answer this question. Basically, you get pregnant at 3 years, stop tamoxifen, and then get it again. So one more point was that once you conceive, you should restart them onto hormonal therapy. Tamoxifen, no, because it will again be teratogen. I mean, it can be excluded in the milk and you should not breastfeed. AIs plus Zoladics may be yes at that time. Next one. So this is the ESMO guidelines which have been shown. Next one. Yep. And this is basically, interruption of after 2 to 3 years of tamoxifen could be considered to allow pregnancy. That's the last 3 lines basically here. So at least 3 years of tamoxifen, maybe 5, preferable 5. Honest, realistic discussion with the patient is what is important as far as I'm concerned.
Dr. Ulas, do we really know how much risk will be heightened? Say 3 years down the line. I mean, does the change in the hormonal profile increase the risk of breast cancer?
So this lady. So we don't know 3 versus 5 years. So maybe if oncotype DX person and you actually know the score, you will actually know. Let's say you do an oncotype for this lady and the score comes as 22, 23. Vis-a-vis score comes as 3. I mean, so there's a lot that we don't know. At least 3 years is what I would say. And then again, depending on what she wants, that's what I would say.
Dr. Ulas, one question from my side, if you may allow. So you said that, what about the fact you mentioned something about letrozole? It may be allowed during pregnancy.
No. After the childbirth.
Okay, so one thing is clear that once the patient is pregnant, no hormone therapy. So that means almost for a year, a patient is going to be off hormone therapy.
Yes. So that's what the positive trial is trying to say. You stop at 3 years, give them a 3 months of whatever gap, and then come back and start the hormone therapy once again. So the results are not yet out.
I think a very interesting point which you mentioned was we might use oncotype DX as a screening test to differentiate between
medical oncologists. No, we have to say something of molecular thing. No, you can't use oncotype to decide whether 3 years or 5 years of treatment. That is not a study to show. It's just a hunch. So as I said, a realistic discussion is the most important thing. There are certain ladies who will say for a 2% risk, we don't want that. I have a lady which a lot of you are co-consultants in. She has a 0.8 centimeter tumor and she wants to go the full Monty. So you don't know. I mean, you have to have a discussion with the patient. That's what I would say. But I will not encourage her to get pregnant before 3 years. 3 years is at least what I would say. 3 months of stopping tamoxifen is what I would suggest.
Okay, I think with this interesting discussion, we go on to our next case. It's a little more challenging. It's a 29 years old young lady, professional. She's engaged, but yet to be married. And she was diagnosed with breast cancer, left-sided. Underwent surgery after workup, and again a T2 tumor, invasive papillary carcinoma grade 3 and node negative. She also had strong ER/PR positive, HER2 negative, but the Chi labeling index was high. She did oncotype DX score for herself, and it was not advised. She did it on her own, and the score came low. The score was 8. Next slide, Geeta. So she did enough research for herself and she decided that she does not want to go for chemotherapy. She opted to go for radiation therapy and hormonal therapy. So I think this time I will ask Dr. Tabassum and Dr. Suruchi, but often these patients would land up with you for radiation therapy after undergoing surgery. So how often do you discuss about fertility preservation with these patients and what are the challenges that you face while having this discussion?
Generally our surgeons would do a good job, and rarely, I mean, there would be a patient who has not been counseled for fertility. But yeah, in a busy setup, you may end up finding such a patient. But definitely, if the discussion has happened earlier, so after the surgery, I would see that it is the right time to discuss the fertility issues, more so because she is not being planned for chemotherapy, which is the most important gonadotoxic regimen. And when she is here with us for radiation planning, so there is an optimal time. That is an optimal time and sufficient time to have a dialogue with her regarding her expectations, her chances of having a successful pregnancy, and allaying her fears or the concerns, what impact the interruption of hormonal therapy will have on cancer outcome, and vice versa. How fertility preservation measures and treatment would have impact on the cancer, and what is the optimal time. I mean, whether she is in a mind frame of getting these options, availing these options and consultation right now, or she wants it at a later date during follow-up. So these are important issues which need to be discussed.
Tabassum, sitting in TMH, Mumbai, busy practice, all kind of patients with different social profile. How often are you practically able to do this?
So I would say by default, I mean, we generally at the initial assessment only we try to flag out patients who have not completed family. So despite being in a busy setup, we generally, at least I would not say that we do have, consultant has a time for each and every patient, but yeah, the oncology residents, they are also trained to initiate this discussion at least in with the patient, and if the patients are really interested, then the patient comes up for a detailed discussion with the consultant.
Very glad to hear that. Dr. Suruchi, how is your experience at Indore? What is the practice?
You're muted, Dr. Suruchi.
Sorry. So we do initiate discussions about fertility preservation as soon as the patient comes to us, irrespective of whether she has been counseled before or not. And we try to understand, because in whatever duration of time she has gone through the surgery or all the investigations, she might have changed her mind also. If she was not ready earlier, she might have become ready now, and to discuss all this. Because in the first appointment, mostly the patients are worried about the diagnosis and the disease. And later, by the time they reach a radiation oncologist, they have a mental frame of what to do. The common challenges that we face in cities like us is, one is the availability and reluctance and readiness of the fertility specialist to go and this thing. And the other thing is the cost in oocyte preservation. And that is the major roadblocks which come across. She is well educated. Otherwise, in tier 2 cities, the social class and the education level is very poor. And what Dr. Raja said earlier, that sometimes the patient doesn't have the right to decide. Then the things are mostly when the patients are from villages or something, the patient doesn't have a right to decide. For this lady, she must be deciding for herself. And so we'll definitely discuss all the options.
So let's hear from Dr. Puneet Kochar. Dr. Puneet Kochar is a fertility specialist. So Dr. Puneet, in your opinion, what are the options of fertility preservation in this case, keeping in mind that she's not yet married, she's engaged, and considering oocyte versus embryo preservation, could there be any medico-legal implications?
So, Dr. Vinita, I'd start off with the direct question that you've asked first. Options for her. The best option in her case scenario would be oocyte cryopreservation, as we know that she doesn't have a partner as yet. The Other option obviously is embryo cryopreservation. Now, 10 years ago, oocyte cryopreservation was not as successful as it is now. So when we started doing fertility preservation, we were keen on preserving embryos rather than oocytes. I remember a lady I probably saw 6-7 years ago who was sent to me with a history of CA breast, operated due to start chemotherapy, and she had just been married. She had come with her parents. She was married, but the in-laws and the husband had not been told about the diagnosis. So the surgery was done while she was at her parental home. And the parents and the lady wanted me to do a oocyte cryopreservation without informing the in-laws and the husband. I took 3 consultations with them and I counseled them to call the husband. I was the one who told them that I'm going to explain the procedure to him. I'm sure he will be happy giving his semen sample. It is not a difficult procedure. The outcome is good because she was one of the low scorers as far as the treatment of CA breast was concerned. Now, this is something I'd like to point out here to all the specialists here. I still regret having made that choice because the husband came. He seemed to be very supportive. They underwent the treatment, we did the stimulation, we preserved the embryos. A few years later, she got divorced. They never accepted her because she had CA breast. And then she was going to marry somebody else. But now I have embryos frozen with the first husband. What am I supposed to do with those embryos now? So if you talk to me now, I would say oocyte cryopreservation. So we've had several pregnancies now with frozen and thawed oocytes. So the option of choice for her is definitely oocyte cryopreservation. Other options are embryo preservation if she and the partner here are very supportive and she's sure she's going to be in a stable relationship with him. She's not even married yet. Ovarian tissue cryopreservation is still experimental. So we only mention it as one of the options. We really don't resort to it. There are no pregnancies reported from ovarian tissue cryopreservation in Delhi as of now. Then obviously we have another option of using GnRH analogs and suppressing the ovaries. I wouldn't say that it is a good option for this particular lady. It is more an option for women who are just entering puberty, for younger females, probably in their teens, when the hypothalamic pituitary axis has just started and the patient and the parents are both not too keen on undergoing stimulation and a transvaginal oocyte retrieval. That is when probably we could try that. So coming on to the protocols, I think Dr. Tanya has beautifully discussed the protocols. We first give letrozole. It is an aromatase inhibitors because we want to keep the estrogen levels low. Now, this is a young lady. Her AMH should be good. So we always start with lower doses of gonadotropins. We don't give 300 to everybody. 150 or 225 probably would be a sufficient dose for her. Usually, a lot of people stop letrozole after 5-6 days. Me and several other people continue letrozole throughout the cycle because it keeps the estrogen levels low. Along with letrozole, ideally we say that even if an antagonist is not given, the letrozole should suppress the ovulation and we should be able to get the eggs. I still prefer adding on an antagonist once the leading follicles reach about 13-14 millimeters. And we trigger when we have a good follicular size of about 17-18 mm, do a pickup procedure. Now, another thing I would like to add here, so this is different from what has been discussed previously. When the oncologist, medical, surgical, or radiation oncologist asks us about the duration that we need before she goes on to further treatment, we normally say an average 2 to 3 weeks. I would like to say that the minimum that we need is actually probably 10 days minimum. Now, that is possible if the patient is mentally prepared to start her cycle the day she comes to us. And if we do a scan, we think that, yes, she's in a good phase to start. So these days, we don't have to wait for the period. We can do a random stimulation, start of stimulation, or maybe just give her an antagonist for 2-3 days and then start the stimulation. The minimum duration of days that she's going to need the stimulation for is about 7 to 8 days. In good cases, this is a 29-year-old, she may respond early. And day 10, we do a pickup. If we get 8 to 10 good oocytes, I don't want to do another pickup. So the scenario where Dr. Tanya said that we would stop for 3 days and then do another stimulation cycle is when we are getting fewer oocytes. So if you're getting only 3 or 4 oocytes, then I would like to encourage the patient and discuss with the oncologist whether we still have time to do another pickup. In most women, one cycle is enough if they are in their late 20s, early 30s. So we do get enough eggs even in one particular cycle. So this is about fertility preservation regarding the third method, the last method, in fact, that we haven't discussed. So I wouldn't really recommend oocyte ovarian tissue cryopreservation. So it doesn't really matter whether we are going to do a
implant again and then stimulate them. This is something which is still not too prevalent in clinical practice.
Ma'am, can I ask one question to Dr. Puneet?
Yeah, please.
Dr. Puneet, we were just discussing that if the patient plans a pregnancy, she has to be off the hormone treatment for almost a year. What is the current scenario medico-legally for surrogacy if, let's say, the patient doesn't want to stop the treatment for 1 year? What are the Indian laws regarding that? Because of lately we heard that the government is really cracking down on surrogacy. Are there any loopholes which can be used for such a patient?
So, hi, Dr. Vikas. Dr. Vikas and I
Hello.
suddenly meeting after years. So, it's a very relevant question, but at a very wrong time. Sadly, surrogacy in India has been banned from January this year. So, the new ART law that was passed has for now stopped all centers from doing any surrogacy. The government is supposed to set up a ART body, and we are all to register with them. As of when they start registering centers, the patients will have to be referred to this particular body to see whether they are genuine candidates for requiring surrogacy. So for now, there are no surrogacy cases being done legally anywhere in India. So which is why once the body is set up, all these patients who are wanting a surrogacy for genuine reasons will have to be referred to this body, and then we get an approval for them and then proceed.
So the rules are not clear yet?
Not yet.
Okay, thank you.
So I think that means the route of surrogacy as of now is closed in India. I think with this, I will invite Dr. Vikas to kindly discuss the next case.
Before you do that, can I ask one more question to Dr. Puneet? Dr. Puneet, which of the two would you have preferred? Say that the husband had not really walked out of the marriage. Would embryo cryopreservation be a better option, or would oocyte cryopreservation be a better option?
Okay, so embryo cryopreservation still remains the standard. When we talk about thaw survival rates, the thaw survival for embryos is nearly 90%. The chances of getting a pregnancy with these thawed embryos are about 40%, let's say. The thaw survival for oocytes is about 10 to 20% low, so it's about 70%. And chances of getting a pregnancy with these oocytes is again 10 to 20% lower. So it is improving, but even now, embryo cryopreservation remains the procedure of choice.
So I had a similar sticky situation where the family, the husband had walked out of the marriage and was not allowing the lady to use the embryos for pregnancy. So that is why I wanted to ask this. Thank you.
Can I also ask Dr. Puneet a question, please? Ma'am, just wanted to know, understand the financial implications of storing an oocytes preservation for a year. Is it yearly charges, and approximately how much in?
The cost isn't about renewal or freezing. Once they are frozen, the majority of cost has already been borne. It is the initial cost which is more. So to undergo oocyte cryopreservation or embryo cryopreservation, a patient has to undergo an entire stimulation and pickup procedure.
Right.
That is where the major cost is. Usually the gonadotropins cost somewhere between 30 to 50,000, sometimes even 70,000, depending on the brand that you're using, the dose that you're using, the mode of injections, whether you're using the recombinant subcutaneous ones or the highly purified, cheaper urinary gonadotropins. The efficacy is usually similar. So for a non-affording couple, the same stimulation, which is done in 70,000, can be done in about 30, 35,000. But the cost of the entire IVF cycle, pickup, ICSI, freezing, is about 1.5 lakhs.
Okay.
So that is what the patient is spending as a lump sum. Now, most centers where they're preserving embryos or oocytes have an annual freezing charge, which is, let's say, about 30,000 is the initial cost, and the renewal is probably going to be another 25,000 per annum. Normally, when we are freezing for cancer patients, they may freeze for, let's say, 5 years altogether, which turns out to be a bit cheaper. So it's not the renewal which is a problem. 30,000 once in a year is okay. But the 1.5 lakh initially, that is what is pinching the patients when they start treatment.
Thank you.
I think Dr. Tabassum also had a question. Yes, Tabassum.
Yeah, I just asked the same question, a question on the chat. I mean, Dr. Tanya mentioned that 8 to 10 oocytes are generally stored, retrieved and stored. So similarly for the embryos, if there are multiple, I'm sure multiple embryos would be stored, but then which one is selected during the pregnancy or while implanting, which one is chosen?
So, ma'am, the difference here is when we are freezing oocytes, we are freezing all the collected oocytes. But when we are fertilizing them with the husband or the partner sperm, we normally culture them for 5 days. We get them to the blastocyst stage, and then we only freeze the good blastocysts. So usually in human embryos, the blastocyst formation rate is about 50%. So let's say you had 10 eggs collected. I'm expecting to get 5 or 6 grade A blastocysts. So that is what we will be freezing. We don't freeze all of them. Now, if we have, let's say 4, 5 or 6 good blastocysts, they are graded depending on the morphology and the size of the embryos. And then when we are to transfer, we normally transfer 1 or 2 of the best quality ones, and we keep the remaining ones frozen for future cycles.
Okay, thank you.
I think with this very interesting discussion, next I invite Dr. Vikas to discuss the next piece.
Thank you, ma'am. So do we have Dr. Arora with us?
Yes, I'm here.
Hello, welcome, ma'am.
Hi,
So, ma'am, this is a scenario which can be a doctor's guilt. So this was a 38-year-old lady. She was nulliparous, married for 8 years, and was taking treatment for infertility. And she develops breast cancer, and the investigation shows that it was ER/PR positive. So there are some reports, and as a medical oncologist, a thought might come that could we have fueled this cancer by giving treatment for infertility? So the question is, does infertility treatment increase the risk of breast cancer?
Yeah, thank you, Dr. Vikas. May I just add on to the previous discussion a point
Yes,
that, when we were talking about the embryo and oocyte cryopreservation, I think all of us, the fertility specialists, have some scenarios where we kind of have a guilt that we should have frozen oocytes, because like Dr. Puneet mentioned, a patient who was recently married, I had a patient who were trying for fertility, infertility. And they were like, trying for 2 years, not getting pregnant. And finally, women gets diagnosed with breast cancer. And, they happily kind of started with embryo cryopreservation because, we also assumed that they were trying for infertility. We didn't discuss much about oocyte cryopreservation, but on day 8 of stimulation, husband backs out, and then woman is left, to kind of preserve her eggs. So I think in the current era, I would say that oocyte cryopreservation should be our counseling strategy, even if they're happily married, because that gives women a reproductive autonomy. And with the vitrification process, which is a freezing process for oocytes, it's a very successful process. And we've got excellent results with cryopreservation. So I think the take home should be that we should offer them their reproductive gametes, freezing only and not the combined freezing. So I'll just come to this question.
So reproductive autonomy is a good word. That's a buzzword for us. So ma'am, coming to the question, if you could enlighten us.
So this is a very, very important question. So this is not asked not only by women, I would say, but I'm sure all fertility experts would agree with me that normal fertility, infertility patients undergoing treatments or patients who have not been able to get pregnant with recurrent IVF failures, they do ask these questions. Will I get a cancer if I don't get pregnant? Will I get a cancer if I have 8 IVF cycles? So there are a lot of risk factors, which we discuss. So like risk factors from the reproductive health point of view is that early puberty, late menopause, the more duration the woman is exposed to estrogen hormone, the higher are the chances theoretically of developing a breast cancer, because she's exposed to hormones for a longer duration of her reproductive journey. So I would like to highlight this study here, which is a recent meta-analysis just published, which has looked into all the treatment modalities we as fertility specialists give to our patients. And it's kind of a relation to the breast cancer treatment. So this was a meta-analysis where the primary outcome was to determine whether there is an overall increased incidence of breast cancer in women who were treated with hormonal treatment. And the secondary outcomes which was, I would say, very, very important, is to look into the individual fertility treatments, like what we give, clomiphene citrate, HCG injections, gonadotrophins, progesterone therapies which we give, whether they are associated with breast cancer risk. So they included total 24 studies, and reassuringly, it did indicate that there was at least no risk of, or decrease, not, I wouldn't say decrease, but there was no increased risk of any of the fertility treatments with the breast cancer. And when this study looked into the individual treatment protocols like clomiphene citrate, which were 9 studies, HCG studies, which were 5 in number, and then I think the next one was gonadotropin, which included 4 studies. So if you look at the forest plot diagram, none of these studies indicated that there is an increased risk of breast cancer association, along with the gonadotropin therapy as well, which included 7 studies. And so they also looked at patients who had 6 or more cycles of IVF, whether that group included any risk in the breast cancer, and reassuringly, no association as well. And again, they looked at the patients who had treatment for more than 10 years, whether that was associated with breast cancer, and again, no risk of association. But it's very important that obviously it's a Western data. And this obviously is not extrapolated to our data. Like, the initial survey, which was presented by Dr. Geeta, where there was one of the questions on access, whether they know where to access the fertility care. The answer was yes in 70%, whereas in the Western world, it was only 5 to 10%. The same survey was done in the Western world. They said they were not aware of the access to fertility care. And that's the reason the fertility board was included in the MDT, in the multidisciplinary team for the oncology team. So I think we should take it with a kind of a little caution that this is a Western data. But yes, at least for counseling purposes, we can reassure our patients that there is as such no association of breast cancer with the fertility treatment.
Okay. So I think I'll go on to the next scenario. Yeah.
Thank you.
Thank
you, Dr.
Vikas.
Arora.
Thank you, Dr. Puneet. I think we'll hear a little more from you a little later. So I'll just go through this quickly, this scenario number 5, which is a 31-year-old triple negative breast cancer, T2N1, married for 3 years with no issues. So she had the surgery. She had a lumpectomy outside first, and then she came to me, and that is when the completion surgery happened with sentinel node biopsy, followed by an axillary dissection. It was positive. So she was keen. She was keen to have her fertility preserved. She had a fertility counseling, and she decided to go for embryo preservation. So when I chanced upon my fertility consultant, she did say that the ova was not of great quality and the husband's sperm count was low. So I could not really make out what it actually eventually would make, what it meant for the embryo that came out of it. So I just want to ask all 3 of our fertility specialists, you can take this question. So how confident are we when we are talking about, the ova quality not being good, the sperm count not being enough? How confident are we of the quality of the embryo? And what are the various parameters that you would check to ascertain fertility fit? And how do you counsel such patients? Does this embryo eventually go on to become a successful pregnancy? So Dr. Tanya, you can take the question, and then I would request Dr. Puneet Arora and Dr. Puneet Kochar also to chip in for these questions, please. Thank you. Very quickly.
I think I just wrote on the chat box because there was a lot of questions coming about this so-called quality check. About someone even asked about use of AI. Now, remember, these are just checks which we do with a visual assessment. Now, there are 2 ways to look at an embryo or an oocyte. You're looking at it through a microscope. So the embryologist who's grading the embryo is either doing by just a visual check. So no one can ascertain really that something called a fertility fit. The younger you are, the better the quality of your oocytes, the better the chances of having a healthy pregnancy. So if a woman is young, be it she is a cancer patient or she's not a cancer patient, her chances of creating a healthy embryo, and as Dr. Puneet said, usually a blastocyst, which is a day 5 embryo, which is reached up to a day 5 embryo, and then we have a gradation. Each embryo is graded differently. A day 3 embryo is graded differently. A day 5 blastocyst is graded differently. So just in a snapshot, I'll tell you there are two ways to grade it. One is a visual, which is what is done. And one is that you actually do a genetic test on an embryo, which is called a PGTA, which is whereby in a day 5 embryo, we take cells and do an embryo biopsy. Now, when we say we're doing an embryo biopsy, are we only checking about the number of chromosomes? Because we know as the age advances, there are genetic syndromes, for example, Down syndrome. So you're looking at an aneuploidy, which is an abnormal chromosome number check. If we have, on the contrary, a person who is a BRCA carrier, you would be doing a genetic diagnostic test, whereby you're doing a test for a particular genetic syndrome. So it's different. So when we see a quality of an embryo, if you've got a fantastic grade 1, you've got a beautiful looking expanded blastocyst, the gradation of blastocyst is different. So if you've got the outer bit, which is called the trophectoderm, and the inner bit, which is called the inner cell mass, you've got a gradation of that. If you've got a beautifully expanded, so for example, a 4AA, you have a very good chance of having a healthy pregnancy in the range of a live birth of 40 to 50%, again, age dependent. So you cannot compare apple to oranges. You cannot compare a 30-year-old to a 40-year-old. You cannot even compare a 30-year-old to a 36-year-old. So you have early 30s or the late 20s, fantastic, 30 to 35 mid-range, 35 to 39, and 39 and beyond, and 42 and beyond. So age is the most important parameter. Then comes the quality. Quality of the embryo is based on the oocyte and the sperm. So Geeta, you've just said that your colleague who did this procedure talked about having not very good ova. So for example, if you looked at an egg which is really good, it should be translucent, shouldn't have granulation. For example, it shouldn't have the dark blackish spots in a cell. Versus you've seen a sperm, which is fantastic. All the parameters are good in terms of the concentration, the motility, the appearance, the morphology. Let's say the ova looked a bit compromised. The sperm wasn't great. Then a procedure called an ICSI is done, which you take a sperm injected into the eggshell, often used very synonymously in India, but it's not the same. IVF is different, ICSI is different. Then comes the embryo. What is the grade of the embryo on day 2, day 3, day 5? Then comes your chances of a pregnancy rate based upon the age, looking at the egg, looking at the sperm, and then looking at the overall quality. However, when we talk about this, it is only a visual. Then comes the genetic testing. One is for the aneuploidy or the chromosome number, and then comes for a diagnosis for a certain syndrome, which, for example, can be a BRCA in our cancer patients. Okay. So when we counseling is really dependent on the whole scenario, on the lady, on the husband, on their individual parameters, on the embryo, on the uterus. What we're missing out here, which I was discussing with Dr. Vinita, is the womb. The uterus is equally important. It is not just the embryo which will lead to a healthy pregnancy. So you've got a fabulous embryo, but you don't have a really good uterus. You're not going to get the same success rate. So in the paradigm, you have to fit in all the pieces of your puzzle to get a good pregnancy outcome. And really, that's how our counseling is. Each counseling is different for each patient. And I can see your slide for a BRCA. So was she a BRCA?
Yes, I'm coming to that.
BRCA patients don't do very well because BRCA patients age faster, they have a poorer quality. So maybe I'll get the others to pitch in. I know there are questions coming about altruistic, so I'll just answer. Altruistic means that you're doing a donation which is non-commercial. It's non-paid. So you're doing it out of the goodwill of God. You're not paying anybody to get your oocytes or be a surrogate either. Everything is done for the greater good, not for the money aspect. That's what altruistic is, which is what is practiced in the West, and India aims to follow that now, which is what we all were doing when we were in England.
Okay, so I'm sure Dr. Puneet and Dr. Puneet Arora and Dr. Puneet Kochar would concur with you. So I do get an idea that it's all under the microscope that you're trying to figure out whether it is good or not so good and what it eventually turns out.
So there are only two ways of knowing it. One is a visual assessment, morphologic, and one is a genetic.
All right, so we will get to the genetics end of it. So this lady underwent chemotherapy and she had submitted a sample for a BRCA1 and a 2, and a test came back as positive for a germline BRCA1 mutation. Now she underwent surgery for the right breast only, and that was a right MRM, and a left prophylactic, and a bilateral reconstruction was done. So final HP is a 1 centimeter residual with 1 out of 12 lymph nodes metastatic. So olaparib was recommended. So now let me bring my medical oncology colleagues. So Dr. Ullas, so what is your take on olaparib? A lot of talk about olaparib, and we all, since we're talking fertility, we want to know, with this plethora of newer drugs invading the medical oncology space, what does it mean for a patient's fertility in terms of olaparib, hormonal and CDK4/6 inhibitors? Dr. Ullas.
So I think olaparib you would want to use in the Olympiad space in the adjuvant setting. Unfortunately, olaparib, that is Lynparza, is a teratogenic. So these are the things which I just took it from the drug insert from olaparib, and you should not get patient should not conceive by an olaparib. Next slide. Or on CDK4/6, that is palbociclib. Next one, because all these drugs are teratogenic. So this was for palbociclib, this was for abemaciclib, and even this was for Faslodex. So except for the AIs, that is the letrozole and the arimidex, everything else is teratogenic. So if a patient is checking abemaciclib or olaparib in the adjuvant setting, pregnancy is a strict no on those drugs.
Right.
Dr. Ullas, what's the washout period? Any idea? I know it's a difficult question.
It's difficult. So I was just thinking, I would say 3 to 6 months. I mean, that's what I would say. I am not so sure.
Still
It has
early.
not been reported.
Right.
So I think, what happens with medical oncology, forgive my saying this, is, once it is done, and then you keep gazing into the future, and then finally you come up with the answer, and then you stop that drug and bring another drug in its place. So
This
let me
was
ask
a
Jyoti.
very, okay, I will not, since I am like,
Counter me. Okay.
Since you are the guest of
Dr.
honor.
Geeta.
Yeah, so I'm the
So,
host.
can I ask one question to the IVF specialist, Dr. Geeta?
Please.
Yes, please.
So the question is, you were mentioning about the BRCA patient having the embryo testing and all that. So do they actually test the embryo for BRCA gene abnormality, and do they actually reject those kind of embryos and select the ones which don't have that mutation? Is it? Is this being done? I don't know.
Dr. Vikas, it is possible. I
Yes.
haven't done it for anybody because none of the patients has actually requested it. So the reason why it is not commonly done is because, one, as we discussed, the cost of IVF is about 1.5 lakhs, can go a little above that. This is without PGT. So when we are not doing pre-implantation genetic testing, that is the cost. PGT is chargeable per embryo. So depending on the number of blastocysts she has, the cost of PGT will go up significantly. So one, it is an expensive procedure. Second, it also decreases the success rate of the pregnancy, of the cycle as such. So what happens is, it is only done on the good blastocysts. So let's say she has 10 embryos, but only 4 of them are getting to the blastocyst stage. So only the ones which are actually reaching the ones which are biopsied. Now, amongst these, most of them probably, let's say, will not be BRCA carriers. So if you look at the cost effectiveness of the procedure, it is not going to be very successful. Also, let's say out of the 4, she has 2 which are BRCA positive, we discard them, 2 are negative. And now when we do a transfer, the chances of a pregnancy from these embryos is still 40 to 50%. So after going through all of this, perhaps she had only 4 embryos. We discarded 2 of them because that baby probably could have had a CA breast when that baby grew older, but otherwise was completely normal. And now we are left with 1 or 2 embryos which may not give a pregnancy. So if you look at the larger aspect, it can be done, it is being done, but it is not something that people usually adapt to very often.
What about the oocyte? You said oocyte is the gold standard. So can it be done on oocyte also?
No, it's an embryo.
Embryo.
So I would say I have one patient who went for BRCA mutation. There was strong family history, 3 sisters. It was the next generation basically coming up. Very well educated, she was living in Singapore and, keen that I just don't want to undergo this. So she did undergo BRCA mutation, and we did ended up transferring a BRCA-free embryo in that. So that is like a PGTM, what we called as a single gene mutation. So yes, it's not easy. A lot of counseling is needed. Patient herself should be ready for it. Our responsibility is to inform, but she should be ready and she should ask for it. Yeah.
And let's say the patient opts for donor oocyte kind of a program. So are the donors screened for all those BRCA kind of mutations?
No.
So there is a possibility that somebody opted for donor oocyte and he might end up harboring a BRCA positive gene in the baby.
Yeah. They could have any genetic problem.
Even though we do ask a detailed family history, but how much is the truth, we don't know.
That's what I was saying. So for the genetic problems, we rely on the patient's history. There are certain tests that we do routinely. Thalassemia screening is mandatory, but BRCA and other genetic problems are not something if the patient is giving us a history that she's negative. And if a patient gives us a history that if a donor, let's say, tells us that she has this genetic disorder, instead of screening her, we normally don't take her as a donor. That's what we usually do.
Right.
Can I just add on to your question, Dr. Vikas, about about BRCAs and in India? So there's a very big difference to what we were doing in London. So when we were doing this at Guy's and Thomas's, remember we are very open abroad to even when we do testing per embryo to say, is it a normal or is it a carrier? And if it's a carrier embryo, is it a carrier male or is it a carrier female? And that is when the patient makes a decision whether, suppose she had only carrier and she has carrier male embryos and carrier female embryos, then they make a decision based on knowing that this could be a possibility or may never be a possibility of getting cancer, as Dr. Puneet has just said. However, in India, you know that with the PCP and DT, we cannot disclose if this embryo is a male or a female. So then often I have patients who come and say, Dr. Saab, agar ye female embryo hui, I don't want her to go through what I have been through. So would it be possible? So I think when we are counseling, everybody should know this, that in India, whenever we are doing testing, for example, even for sex linked, we are not able to give. So we will get a report, but the report will not say that is there a carrier male embryo or a carrier female embryo. Now I know in the cancer perspective, there can be differences, but a BRCA male or a BRCA female, both can have an issue to develop cancer later. But I think our mindset is slightly different. And also as doctors, we should know that this is not a facility which exists here in India compared to the West. BRCA, we can test and we do test. It is expensive, as Puneet said. It is done on a day 5 or a day 6 embryo, which is a blastocyst. They are done in highly trained labs. And the genetic result which comes out will not tell you about the status of the embryo in terms of it being a carrier male or a carrier female. So I think that is the take home I want everyone to know.
Okay.
Thank you.
Right. So let's move on because we've some more ground to cover quickly. And that is, Jyoti, could you just tell us, Dr. Jyoti, if you could just take us through Her-2 and the immunobits, how they impact fertility.
Right. So for both these agents, there's paucity of data, especially for immune checkpoint inhibitors, because especially in breast cancer, we have just started using them. So for Her-2 targeted agents, as you were showing in the previous slide, that bar table, this is based on the data from L2 trial, wherein they compared the rates of treatment-induced amenorrhea. These patients had received chemotherapy with Her-2 targeted therapy, which was either of these 4 options. And you notice here that the amenorrhea rates were similar. So it can be, next slide, please. So it was presumed that these are fertility, oncofertility discussion could focus on the chemo effect on fertility rather than on these agents because they are presumably safe. For immune checkpoint inhibitors, we know that they can impair fertility and the mechanism could be primary hypogonadism or secondary hypogonadism, and they have to be avoided during pregnancy and shortly before pregnancy. Now it's further known now in more recent studies that there is a recommendation regarding minimum time from end of therapy with these immune checkpoint inhibitors and beginning of pregnancy. So for example, it's 3 months for ipilimumab and durvalumab and 4 months for pembro, which we have started using for breast cancer. But they are definitely not safe during pregnancy. They must be avoided.
Thank you, Jyoti. And because we've all come around to talking
Okay,
about
Jyoti, one question. Is there any percentage which we can say that these many % patients will for sure never regain their reproductive health, a younger patient, not a perimenopausal kind of a patient, or all of them by and large after some time regain?
So in the initial table that I mentioned, wherein I had classified the anti-cancer agents into high, intermediate, low, very low. So in that, the HER2 targeted agents come in very low risk category. They are possibly safe. The immune checkpoint inhibitors are, they are not safe. And we don't really know. So it's best to avoid and best to alert the patient. So right now, the recommendation is when you counsel the patient about immune checkpoints effect on fertility, you should be playing very, play with caution, and you should sound that, it could affect, we don't know for sure. For HER2, it's said to be safe, but they are almost never used alone. So the effect of chemo remains on fertility. Right. So that's how the discussion should, move forward.
So because you can go ahead with this one.
So we have Dr. Aparna here with us. So Dr. Aparna, how does the geneticist check the quality of the DNA? So oocyte, my understanding is it's difficult. Embryo, it's easy in relation to chemotherapy, hormone therapy, targeted therapy, and immunotherapy. So basically the question is, do you just simply check for mutational problems which we know of, or is there a screening test by which we can just find out any mutation problems in such embryos or oocytes?
All right. Good evening. All right. Thank you for that question. All right. Next. Can we go to the next slide, please? Right. So I think this has already been explained in detail and very, eloquently by Dr. Wadhwa about the gonadotoxicity and how it, kind of affects women with breast cancer and how it could possibly affect the fertility. Can we go to the next slide, please? I think. So essentially what happens is that when you have chemotherapy, there are two particular mechanisms that are getting applied over there. One is where the first one over here, which we see, is your a DNA lesion gets induced, right, by chemotherapy. And what it does is it activates the repair pathway. This is your BRCA pathway. This is your DNA damage repair pathway. And because there is a mutation in this pathway, it is there's a mutation, there is chemotherapy. What it does is it's not able to repair. And this induces a transcriptome factor, which is called the TAP 63, and this mediates what we call an apoptosis of germ cells. And this is a common phenomenon we see in our patients who undergo taxane therapy, anthracyclines, platinum therapy. The second thing that we see with our patients with chemotherapy, because for me it's always going down to the molecular part of it and understanding the molecular profile, is actually it destroys the growing follicles, which then leads to the reduction of your AMH levels. And what happens in that is that this is due to the this is due to the upregulation of what we see in the PI3K, your AKT, your P10 pathways, and this recruits what we call a primordial follicles, and that accelerates the activation of follicles, which ultimately leads to the depletion of your ovarian reserve. So because we kind of understand them on a molecular level as to how these different agents affect the pathways, which in turn affects the ovarian reserve, what we've actually come to understand is that be it your BRCA1 carriers, they have, as Dr. Tanya already said, they have a 25% lower AMH concentration versus those, and a lower ovarian reserve versus those who are non-carriers. BRCA2, we don't really have a lot of evidence around it. Then you've got, again, a lower ovarian response rate and lower eggs, which are produced in your BRCA1 versus the non-carriers under ovarian stimulation. And ovarian 1, in addition to that, also has a propensity for ovarian failure and is far more higher versus BRCA2. BRCA2, certain mutations will eventually lead to ovarian failure, but not all of them. I think there's still work around that area. So what has been devised from a genetics perspective as to understand is that there are two genes in particular, which makes this workflow, the screening progress, the screening flow a little bit easier. One is obviously looking at the BRCA1 status. For now, we're just focusing on BRCA1 versus BRCA2 because the data is more with BRCA1. Sorry, can we please go to the previous slide? Sorry. Right, sorry, yeah. So if you look at this flowchart over here, and there's the FMR1 gene, which is actually what we use in Fragile X. But patients who have pre-mutations in this and BRCA1 or a BRCA1 mutation actually have a higher risk of having a low ovarian reserve and having ovarian failure. So this is one of the key molecular markers, the key genetic markers that we look for, in addition with on day 3, where we look at the FSH, AMH levels. This is one. Now, if a patient comes negative over here, there's a lot of research, and this is work in progress. And I think this is where we're going, because there's a lot of talk around oncofertility, is looking at these other 7 genes. If there is a mutation in one of these genes, again, this correlates to the fact that your patient actually will not, will have premature ovarian, will lead to have a depletion in the ovarian reserve. So for me, I think these are the algorithms that we are using today in the lab. Next, please. And and this is the screening mechanism that we are using today. If we do feel that a patient is having phenotypic features that are leading towards primary ovarian insufficiency, in cases like that, we are using targeted NGS panels, just because India is very cost sensitive. The overall procedure is expensive. So at least to start off with, we are doing a basic targeted panel where we're looking at your BRCA1, your FMR1, and if that's negative, then we're moving on to the other panels. So very simple NGS. And sorry. I think the slides have gone ahead. Yeah, no, it's just that when we are talking about all of this in our clinics as a genetic counselor, I think we're the first point where a patient is, we actually sit and have a conversation with that patient and explain to them what this BRCA mutation means to them. It's not just about their breast cancer, but it's also, the implications it could have to the rest of their family. She's a 31-year-old female who's BRCA1 positive. We already know that, possibly, the chances, the failure rates are slightly higher on the reproductive side. So these are conversations where, you can, it has to be very delicately explained to a patient. So for me, it's more about understanding the patient's mindset, where they are, how they are feeling about the situation, and walking them through this whole process and telling them that there is an option available, especially when she's 31 years old. Should a patient decide that they do not want to go down this path and they do not want to do oncofertility, but they want to get rid of this gene in the next generation, it's a death sentence. And you hear all sorts of words. It's a curse, it's a death sentence, it's a whole lot of negative words that are used around BRCA, having a BRCA mutation. So at points like this, you introduce them to the concept of PGTM, where we can check in the embryo that if there is a potential BRCA mutation, before we do an implant. But again, the pros and cons have to be, every time a patient comes up with these ideas and concerns and notions, you have to list out in a very autonomous way the pros and the cons. You have to have a very open dialogue without sugarcoating, but obviously being sensitive to a patient's needs and their cultural beliefs and their perspectives, and without being condescending, but just being very delicate and putting all those words across, and having a patient build confidence and make a decision, an informed decision for themselves regarding this. So that's what I usually do. And the key point in this is, because we are involving genetics, where we are trying to, in layman terms, reduce the effect or remove that BRCA gene, a patient has to be told that just because, we may be, maybe implanting a BRCA, an embryo which does not have a BRCA mutation, but that does not mean that your child will not have the disease in the future. There are chances of sporadic cancers. So all this has to be very, informed consent is important, and all this information has to be very clearly disseminated to a patient. And this is not in one counseling session. I go through a series of 3, 4, 5, 6 sessions till I know my patient's 100% sure when they make this decision, and if this is the path that they want to choose, that they're doing it for the right reasons, and they've understood the good, the bad, and the ugly of this.
Thank you, Aparna. Thank you very much. So I think we have discussed this bit already. This is in a 40-year-old, even if she's HER2 positive and she is going to require a year-long treatment. So how does one counsel such a patient objectively with time running out on her? And I think Dr. Vikas had asked this question about the current status of surrogacy. But, I think we are still kind of immature in terms of discussing adoption. This is something that I think we need to possibly communicate in the same breath as we discuss fertility preservation and having their own biological child. It is important to discuss this option of adoption as well, which is done pretty freely in the West. And I think, this is something that we don't. So let me just ask Dr. Puneet, um, how does one counsel such a patient where, time is of essence, like everybody's already said that? And how does, how do we bring the adoption dialogue also into the conversation? Because it is a great option, because there are so many kids who are orphaned and need love and care. Dr. Puneet.
So I think it's important, like I think Dr. Tabassum mentioned in the chat, that it's a realistic counseling what we now talk about. And I think it has to be in every aspect of care of any cancer patient. And especially if the woman is, 36, 37 odd plus, when we know that the physiological, the baseline ovarian reserve will decline anyway, be it cancer or be it she receives any cancer treatment or not. This is a normal physiology, because it's a beautiful chart which shows that after the age of 35, 36, how this reserve is declining, and the chances of conceiving spontaneously or chances of having spontaneous miscarriages do increase that way, and the live birth rate decreases. And this is based on the fact that a woman is born with a set number of eggs, and the maximum number of eggs are when she's intrauterine in her mom's womb. That's around in millions. And the time she starts her menstrual cycle, which is when she attains her puberty, the number of these follicles keep on declining at a very rapid pace till she's 30, 34. And that's why we say the peak reproductive time is between the age of 24 to 34, 35. So I think the realistic counseling is important. Yes, she can be given all the options of preserving fertility at this point, which can be oocyte, which can be embryo or whatever, or ovarian tissue, depending on her ovarian reserve. Yes, the discussion of adoption, I agree with Dr. Geeta, it's important. But if we see the Indian scenario of adoption, it's little, because there's only one agency, which is CARA. And it is all stuffed up. It's too busy. And the timeline for adoption is quite, 1 year, 2 year. And sometimes the parents have a desire that we want a newborn child, or we want a child who is less than 1 year. But that's not an option in CARA. So it's also what patients want. Maybe they may not be able to achieve in adoption what they really want to, and hence they prefer undergoing donor oocytes or donor embryos, because at least they'll have the feeling of being a mother, of carrying a child, rather than just adopting a 3-year or a 4-year-old child. So I think it should be discussed, yes, but I think in my personal opinion, what I have seen is patients do kind of go away from adoption in the Indian scenario. The reason being it's just a little complicated. It's only one agency. I would like to hear what others think, but that's what the scenario in India is.
Thank you, Puneet. And I'll now stop sharing and just hear any last words from our fertility specialists and all the experts that we have had on board. And then to sum it up, I think it's a great idea, because so much of information has been shared, and I think a lot of it has been kind of new to our ears. And I think it will help us understand this thing more and make our conversations with our patients more meaningful. So, just to sum it up, I will also call upon Dr. Rajat Saha, because he's been hearing very carefully and taking down notes, so which will be of help so that we have a take-home message on this. So, Dr. Rajat, you can go ahead and share screen and just share our take-homes. Before we put up the last slide, we've got about 38 people. So those who have come in have stayed. So that's a great thing. I think all our experts have done a great job.
Question from the perspective from any of the medical oncologists or the surgical oncologists. When we talk about situations of oncology in India, I think whereas the fertility experts, we also would like to know about the tumor biology of the Indians. Our ethnicity is different. So we've done studies in India, and we've seen that a 35-year-old is not same as a 35-year-old Westerner. So we know that our fertility, we think we are the most fertile capital of the world. We are not. So when I talk about realistic counseling, we also have to know whether you've frozen 5 oocytes, 2 oocytes, 6 embryos, or what we have, because we know we age faster, and that is for the general population. Now, what about our cancer patients? We often, we think and we talk about getting these consortiums. We have them. It's a bit fragmented. At least we are having these conversations. So what about your tumor biology? Because not every stage 1 is the same, not all stage 3 are same. What about the Indian scenario? So what about the Indian breast cancer patient? Because a roadblock from our side sometimes is when the patient comes and sometimes is actually asking us, what is the 5-year survival? At the end of the day, you know what we were saying, last is, resonated my words. It is about giving a live born to a healthy mother. What is our survival? So when we talk about survivals, we're all talking about the West. What about the survivals of the Indian patient and our Indian data? If you could guide us, then that would help us as well. So from our fertility perspective, we know that when we compare to the West, we are a little bit slower. We're a few years behind. Does that happen in terms of oncology for breast cancer as well? I mean, all the oncologists, if you could guide us on this.
See, very, very good practical point from your side of the table is that, yes, we are definitely facing breast cancer at a comparatively earlier age as compared to the West. That is pretty clear. Secondly, yes, our treatment outcomes may not match the numbers which we see in the various Western articles in JC or NEJM. It generally not. That's an honest opinion from our side. But yes, we still can put a number on our patients even in the initial visits, and we kind of definitely are not at par with the Western data, but we are definitely somewhere near it. Means that's what I can't put a number on it, but yes, we're definitely near it.
But there is one thing that I would like to add, that when we are talking about breast cancer per se, we know that our patients not only are younger at presentation, but they are at higher stages because of the lack of awareness. So we have about 60% of our patients who will present as locally advanced or advanced breast cancer. And the early breast cancer hardly amounts up to about 30-35 in best of practices. So I think that is one of the reasons that we have a poorer outcome as compared to the West, where say if you go to MSKCC or you go to Guys and Thomas, you will see a different disease. It's not just that you're treating breast cancer, you're seeing a different disease altogether. There they are having a tumor board on a locally advanced breast cancer because it is an internal memory node and they don't want to operate or don't want to radiate. Here we are talking about it on a daily basis because we are 6 of our patients out of 10 are the same kind of patients that we are seeing. So that's one of the reasons that our survivals are not as good. And I think if it was really stage matched, maybe we are doing a good job.
Fantastic. Fantastic.
And not to forget that we are dealing with a greater proportion of triple negative breast cancers also in India, which is known to be more aggressive.
What about the BRCAs?
So triple negative is known to have higher frequency of BRCA mutations, 1 and 2. So that makes the matters worse.
So generally, sometimes when they come to us, we don't have the status. But I think from our point of view, we should just, as we would, think, if we don't have the hormone status, think of everybody as hormone positive, do a letrozole-based protocol, think of everybody as a potential BRCA carrier, do counsel them, especially if it's a young triple negative, as you've just said. So I think that will make it easier for the fertility specialist as well to give a wholesome and a realistic, all kind of solutions, and then let the patient decide based on her age, her ovarian reserve, also stage of the disease, and what facilities are available to you, which tier city you are in. And again, I will say that please also know the success rates of your own lab, because when we say that what is the success rates of oocyte freezing, it would be different in a tier, when we're in the metropoles, it could be different if you don't have, that kind of a success rate in maybe the interiors. So please, when you have this consultation, also have a realistic consultation with your fertility expert who can guide you as to which is the best outcome for the lab, so that together we give the best success story to the patient, which is live birth rate, not just freezing a gamete.
Thank you. Thank you so much. This discussion, I'm telling you, if we decide to hold one day or possibly a 2-day meeting, it can go on forever. But I would request Dr. Rajat Saha to just do the, take-home messages for us. And then maybe we can just run a poll. I mean, although we're just about 36 people on board, I think it'll still be interesting to do that. So, Dr.
Yeah,
Rajat.
so let me, okay. So an excellent discussion so far, and let me just go to my take-home points, and I hope it echoes the take-home points of other clinicians as well. The first and foremost thing which I learned from these last 1.5 years of, means 1.5 hours of discussion is we need to break the clinician inertia. That is very, very important. We need to break an inertia from our side, and that is so important to the happiness project, to the success of the happiness project. Another thing which has been put forward is we need to harness the tremendous passion of our fertility experts like Dr. Tanya, Dr. Puneet, and Dr. Puneet Arora. And they have a lot of passion and in actually counseling our patients, and we have to just utilize their this potential. And we have, as they have already reiterated, we have a lot of options for fertility preservations. Few of them are oocyte preservation, embryo preservation, ovarian tissue preservation is there. So all these are there with us. Ovarian tissue slightly more experimental, oocyte and embryo preservation very much practiced, very much practiced. Another thing which I learned from this is there is no need to time the periods. Earlier, I used to think that you have to time the periods. You have to get the preservation done at a particular period, but there is no need to time the periods. And our fertility experts can get the oocyte harvesting in minimum time of 8 to 12 to 15 days approximately. So that is, I think, so a good time. What we need is a good counseling from our side also. One last point what Dr. Tanya made is a BRCA counseling. In addition to the hormonal status, a BRCA counseling and information is needed on our patients before they start the fertility counseling. So that is also a very important thing which we need to know in our patients at the initial presentation. Yes, there are a lot of roadblocks in this happiness project. Definitely the cost of therapy is there. The success rate of therapy is there. The lack of insurance coverage for these kind of treatments is very much there. And obviously we as clinicians have to break the patient ignorance and panic, which generally accompanies the diagnosis of cancer. Yes, the risk of recurrence, stage and type of cancer definitely takes precedence, whether it's a TNBC, whether it's a high grade, whether it's a high risk, all these definitely takes precedence. Pregnancy, one important point is pregnancy should not be contemplated in the first 2 years after completion of therapy for breast cancer. So that is a ballpark figure, means 2 years or 3 years, but yes, 2 years definitely. We definitely as medical oncologists need to know the rate of permanent amenorrhea with various chemo protocols and then counsel our patients likewisely. That can break their ignorance and pattern. Wash off of tamoxifen before conception is 3 months. So that is a very important figure which we need to remember. Wash off of trastuzumab before conception is 7 months. That is what Dr. Jyoti pointed out, very important. CDK4/6 inhibitors and olaparib are teratogenic. That is what has been pointed out by Dr. Ullas. Wash-off period not known as of date. Data on immunotherapy still evolving, and immunotherapy definitely is contraindicated with pregnancy. So we need to definitely stop immunotherapy if we are planning to conceive. And AMH levels and antral follicle count can be done to assess the fertility even prior to the treatment. So how fertile is our patient? We can see by doing these very simple tests. Dr. Puneet Arora brought out a very pertinent point that she showed a huge meta-analysis which showed that there's no risk of increase of breast cancer with infertility treatment. So it is pretty safe. And I think so. I must have missed a lot of points in this highly educated seminar. Over to you, Dr. Geeta.
I think another point was fertility autonomy.
Reproductive autonomy.
Reproductive autonomy.
Yeah, I think that was a fantastic word.
Yeah.
Because I think, women have to take their lives in their hands, and a lot of times the decision does get clouded by the various social and socio-cultural obligations that they have. And I think taking their life in their own hands again becomes very, very important. So let's just have a very quick poll, although I think, we had a very high polling for this question that's going to come up. Team, can we have the post poll, please, very quickly with as many people as we have. Okay, so would you be willing to counsel young bride regarding starting tomorrow? So we had yesterday, so we had about 70 odd people, 78 I think odd people who said yes. So I think we can go ahead and answer this. Okay, and the second question, just 2 questions on this one. So the fertility specialists are going to get busy now. Okay, so knowing that we have differential access to expertise and cater to a population with varied socio-cultural background, what percentage of patients are you confident that in collaboration with your fertility specialist, you will be able to influence, meaning the decision of the patient that you would be able to influence? How many do you think you can? Because lots of time we fail. Despite our best of efforts, patient decides to go the other way and not get counseled and not get fertility preservation done.
Can I say something, Geeta? Even if they choose not to do fertility preservation, but we've done the counseling, I think we won the battle. As long as we're always there to counsel them and support them, I think the battle is won. Whether they choose to do it or not is their individual choice with their circumstances, be it the cost, be it their thinking, be it their approach to cancer. But we should be there to support them. As long as a fertility person can guide them and give them the options and give them the support to say, you take your choice forward based on the information and the scientific evidence we have, I think we've won the battle.
Excellent, excellent. I think that makes a lot of sense. So can we just have, let us just quickly have a look at the poll, because I think I can almost guess what it is going to be. After such an excellent, invigorating session, a lot of questions that we had in mind have got answered. At least I am wiser for it. I'm sure all of us are. But I think it is all collaborative, and I think, we need to break down those barriers of communication that a lot of times comes in the way, because they are quite at an arm's distance, a phone call away, like I would like to say. And I think we need to utilize their services more often than not. So can we have the poll, please? Wow. Nothing less. So I think the belief is very strong that it has to be that way. It cannot be any other way. So starting tomorrow, at least all those who attended this meeting are going to offer fertility preservation as an option and send the patients to the fertility specialist for counseling. Second question, answer to the second question. I'm sure the conviction has also gone up. I'm very sure. No. So we do have a mixed bag, but I like it. About 45% of people think that it is possible to rev it up to 25 to 50. I think even 25 to 50 is a great number. If you can get there, so I would say 10 to 50%. So 10 to 50%, close to a 78, 80%. That's brilliant, I think, because I think we're still struggling with this. We are, realistically, if you look at it, we are less than a 10%. If you put the entire country into perspective, we are less than a 10%. But if you can get to that 10 to 50%, I think that will be magic. So there has been, I think, we will be putting this presentation on the YouTube. And as Dr. Jyoti Wadhwa said, we need to write this up. It is easy to write it up. So I think I will get somebody to write all this up, and I will seek your help again. Because, we need to have this Indian concept to this whole thing also, just as Dr. Jyoti Wadhwa mentioned. It is very, very important information coming out of this discussion. And I think we need to reach out to everyone possible. Sorry. If the decibel level goes up in metro cities like us, it will definitely percolate down, and the noises are already being heard, because we have got Namrata sitting in Ranchi and saying that it is happening, and I'm sure that is the only way it will percolate down and reach out to everyone, because like I said, it is a right. Reproduction is a right of every woman, and why should she not be complete? And see, while the medical oncologists and everybody else is making sure that women are living longer, let them not live with a regret. They need to have made use of their choices that are there. Thank you very much. We've had a great session, and it did not seem like it has been 2 hours. And we will be coming back again next month with another very interesting set of cases this time to discuss. Till then, thank you very much and have a very good night. Thank you all the experts.
Thank you, Geeta.
Thank you.
Thank you.
Thank you very much. Thank you.
Thank you. Good night.
Ma'am, can we close the meeting now?
Thank you.
Yes, please. Yes, Pooja. Please go ahead.
Okay.